Dear colleagues, it is a true pleasure to welcome you to Chain's World Leadership Dialogue, which we have entitled Diving into the World of Data, Developments in Global Health Inequalities Research. My name is Terje Andreas Eikemo, and I am a professor of sociology and the leader of Chain, the Center for Global Health Inequalities Research, based in Trondheim in Norway, where I am now. Now, this session will explore new developments in the field of global data on health inequalities and their determinants. And I will now share my screen so you can have a look at my presentation. Now, the aim of this dialogue is to explore how these new developments in the field of data can change the research and policy arena, aiming at promoting health equity. I will now briefly present the agenda of this session. All speakers of today are highly profiled and they don't need much introduction. Our first speaker is Dr. Samira Asma. She will address data gaps and potential solutions in her talk. Our second speaker is Dr. Emanuela Gakido. She will tell you more about the work that the Global Burden of Disease Study is currently doing on education. Our third speaker is Dr. Salma Abdallah, who will explain how the 3D Commission is using data science to examine social determinants of health to inform policy decisions. And finally, Dr. Nicole Valentine will inform us about the lessons learned from WHO's work on the social determinants of health equity. After all presentations, I will ask for a brief discussion, and I will then end the session with a few concluding remarks. Now, before we continue with our speakers, I will make a short introduction in which I will first argue why it is such an urgent task to improve our data on health inequalities. And then I will inform you about the work that Chain is doing in order to improve the availability of comparative data that can be used to promote health equity in the world. There is no country in the world that has been able to protect their populations from the negative health consequences of poverty. And I'm going to illustrate this problem with this graph. Now, they present child mortality in rural regions from 1985 to 2000 using data from the DHS survey. They show that children born by mothers with high education live longer than those born by less educated mothers. Now, this pattern is consistent everywhere, although with different magnitudes and variations. Now, let's have a look at what happened 20 years later. You can see that even if child mortality has been reduced, it has actually been cut in half. Further improvement is hindered because children born by less educated mothers still have higher mortality. The pattern is still the same. The social gradient in health is everywhere, and it's evident at all times. Now, health inequalities, they start to emerge during early life. They endure throughout our lives, and they are transmitted through generations. The presence of such inequalities is among the biggest public health challenges that the world is facing today. Despite this, there is no system in place to monitor the extent and variation of socioeconomic inequalities in health over time and across space. What we need is data with sufficient geographical span and analytical depth to gain knowledge on the extent, on the development, and explanations of socioeconomic inequalities in health. Chain's vision is to promote health equity through data capacity building and research excellence. Our aim is to provide advanced monitoring of socioeconomic inequalities in health, mortality, and their social determinants in all countries with available data. This task has suddenly become more urgent with COVID-19, as we know that the pandemic is hitting societies unequally. However, comparative data with sufficient depth, which cover many countries, is hard to find, and the availability and quality of existing data vary enormously, disfavoring countries in the global south. I will now provide you with 3 examples of how change is attempting to address these gaps. Our first strategy is to use the data we already have. In order to support evidence-informed policymaking, we want to map and collect existing data on mortality by cause of death, chronic conditions, infectious diseases, and living conditions, which in turn can be broken down to socioeconomic position in as many countries as possible. We want to create a global data and research infrastructure, which will be made available to others to the degree that data sharing rules, of course, allow us to. In order to make this happen, global collaboration is needed. We need to share our data and we need to work together. If some of the viewers here share this ambition with us, do not hesitate to get in touch. Our second strategy is to take new steps in ensuring global comparability. Now, we do this first by implementing a global health equity survey. The survey will be based on our health inequality module, which was integrated in the 7th round of the European Social Survey back in 2014. This was the first large-scale survey that was able to combine detailed measures on health and health behaviors with detailed measures of living conditions and working conditions, on healthcare utilization, and of the social stratification systems of societies. A sociological medical survey. We have already secured a new data collection in 30 countries, which will be implemented in 2 years from now. Therefore also making it a key or the key data source for the evaluation of the social, economic, and health consequences of COVID-19. Because we are basically repeating the same questions from 2014 before the crisis with a new set of questions in 2 years from now. Now, there are certainly other initiatives out there, and we hope to join forces also with those who share this ambition as well. So now we'll go on to our third strategy, and that is to integrate socioeconomic position into the global burden of disease study. Emanuela will tell you more about this in her presentation. This is joint work, and I think this will result in a scientific revolution in the field, because the contribution of education can be compared with the contribution of all other risk factors in the global burden disease study in all countries. The GBD study has enormous impact on countries' abilities to respond to health crises, so I think this is a major step forward for science in our field. Now, this was just a snapshot of a few of Shane's initiatives to improve global data on health inequalities. But in the work that we have done so far, we have met some challenges that I know that many of you are sharing with us. For example, it is a challenge to obtain data that can identify vulnerable groups and the steepness of the social gradient that goes through the society at the same time. It is a challenge to obtain comparable data of high quality, because geographical span and analytical depth, they don't go hand in hand. Basically, it's a challenge to obtain comparable data of high quality, because as I said, geography goes sometimes on the expense of the analytical depth that we're trying to obtain. There is a lot of data out there, so it's also a challenge to identify all sources. It is also a challenge to identify the explanations on different levels, going from the individual level to the neighborhood level, family level, the level of societies and countries. So that is also an important part of the picture. And harmonization is a problem, or a challenge. Let's call it a challenge, because the type of data vary a lot. And finally, it is a challenge that not all data can be shared, because it cannot be shared because of data protection rules, or because basically it's too expensive. But most of these challenges, if not all of them, can probably be met if we decide to work together in a synchronized and effective way towards the common aim, namely to promote health equity. And please reach out to us and follow us on our various channels. And with this introduction, which included a presentation of our own experiences in the field, I will now leave the floor to the next speaker, Dr. Samira Asma, who will tell us more about data gaps from her perspective and including some possible solutions.
Thank you very much, Terje, and thank you to the organizers for having WHO be a part of this exciting and a very important topic. I'll be briefly talking about the importance of counting everyone, because everyone counts, and how data is very important as we look forward towards achieving SDGs and managing through the COVID pandemic. Health for all cannot be achieved if we don't know who we are leaving behind. As a matter of fact, we are leaving many people behind, and many of them in the most vulnerable settings. As you have seen, COVID has uncovered long-standing problems which need to be addressed urgently. And we have a small window of opportunity. We have only less than 10 years to achieve the SDGs by 2030. We already knew we were falling behind, and COVID has also threatened to put us further behind. So the question is, are we going to focus on improving lives, being prepared, improving health, preventing deaths and diseases, serving our citizens, or continue to fix the data problems? The answer is simple: because we have the tools and we know what works. So given that the window of opportunity is small and it is closing quickly, we must act now to address the data gaps. And what solutions we have? Timely, reliable, and actionable data is vital to achieve health for all, to leave no one behind, to be prepared, to meet the SDGs. When we dive into the data, what we see is that we don't have disaggregated data by many of the variables that are important to close the equity gap. When we dive into the data, we see that countries are still unable to accurately report on most basic health information, such as deaths, number of deaths, and causes of death accurately. Many countries are still experiencing problems and facing challenges. There are 1 billion people that are invisible because they don't have birth registration, or they die without death certification, or we don't even know the causes of death. And it is extremely important for us if we ought to meet all SDGs, because this information alone informs at least 12 of the 17 SDGs. When we dive into the data again, what we see is that only 26 SDG indicators have sex disaggregated data that has been reported in the World Health Statistics report of WHO. And in terms of primary data, what we have observed is approximately 50% of the countries can have primary data for even less than half of the SDG indicators, health-related indicators. There are altogether 59 health-related SDG indicators. When we dive into the data again, we see that the average out-of-pocket expense for health care is unequal, and you see how the lack of information prevents us from addressing the data gaps and leading people into poverty. So there are a lot of inequities if we don't have good data. When we look at COVID, now is the time for us also to quantify the direct and the indirect impact COVID is having on the population, as well as informing the effective responses. With regard to data, there is often too much delay, or too much is unknown, or too much is incomplete. And the solutions I will turn on to. The good news is we have goals. We know where we are heading. We ought to know where we are heading is in the right direction, and we are making progress. And if we are not making progress, we need to know that we are not making progress and make course correction very quickly. And WHO's put forward in its strategy triple billion targets to accelerate progress towards SDGs. 1 billion more people benefiting from universal health coverage, 1 billion more people protected from health emergencies, and 1 billion more people enjoying better health and well-being by 2023, so that we can take a stock and accelerate moving towards 2030. WHO, in response to the data challenges, working in collaboration with multitude of partners, put forward a technical package called SCORE. It represents key elements that are necessary to strengthen countries' data and health information systems. It has 5 components, from improving population surveys to improving civil registration, vital statistics, optimizing routine health information systems, reporting, making data easily accessible, and finally, using data to inform policies and deliver impact. We also need to look at innovative tools and technologies such as the geospatial information systems that can be used to access, track movements, healthcare facilities, etc. We also need to have access to all types of data in a one-stop shop or one place. There are many partners that have contributed to this effort, but we can do better as we go forward. Partnerships is very important. Both political and financial commitment is necessary to invest in people, invest in data capacities, and have really data champions from subnational levels to national levels, regional and global. Capacity in analytics that many of our partners here on the panel coming from academic institutions. Just looking at the Institute of Health Metrics and Evaluation and the upcoming Global Burden of Disease new study provides a very important metrics for population health trends globally. I'm fortunate and to be a part of the 3D Commission, and Salma's work brings together the social determinants, the data, and the partnerships around this. And finally, in closing, I just want to make a note that good public health decisions across public and private sectors are necessary so that we have timely, reliable, and accurate data so that we can use the data to drive our policies and programs effectively. Coming back to my point and the question that we shouldn't be waiting next 10 years to address the data gaps. We have the tools, we have analytical tools. We have the means to support and strengthen capacities in countries to strengthen primary data collection so that our estimates are more robust, more accurate, and making data available while safeguarding the privacy of our citizens. Thank you. Over to you.
I would like to thank Samira Asma for her presentation, which was a really valuable contribution to this session, I believe. I would now like to invite Emanuela Gakudo as the next speaker. Emanuela, please.
Hey, thank you very much, Terry Andres, and thank you, Samira. I am delighted to be here today, and my presentation fits very well after the remarks by Dr. Samira Asma. The Global Burden of Disease study is related to the E of the SCORE dashboard that WHO has presented, and our goal is to provide information so that it can be used by policymakers to enact change. Today is a great day to be talking about the Global Burden of Disease study as we are launching the results of the 2019 Global Burden of Disease right here at this conference today. I wanted to talk about something that is coming up in the GBD in future years, which is an exploration of the social determinants of health. It is work we're doing in collaboration with Chain and a large group of scientists and researchers around the world. And the notion behind it is that it is not just enough to quantify what kills people and what makes us sick, which the GBD has been doing for over a quarter of a century now. It is also important to quantify the contribution of other factors such as social determinants, and also come up with policies that can avert the health loss that they're causing in the future. So our first exploration of the burden due to social determinants will be around education. And today I just want to share a few preliminary findings from it. Of course, as Dr. Asma was just talking about, the Sustainable Development Goals also have a focus on education. And this slide, if you can see it, we're showing the progress towards SDG 4, which has to do with primary, secondary, and tertiary education. And this graph on the right maps progress over the last 50 years and some projections into the future to 2030, which is the target for the Sustainable Development Goals. The top panel is showing global progress on completing primary education. The middle panel shows secondary education, and the bottom panel shows tertiary education. And what this graph tells us is that while there's progress around the world in all levels of education, the gaps that were observed a few decades ago are narrowing predominantly for primary education, and that could potentially be attributable to emphasis on primary education as part of the Millennium Development Goals earlier on. But we see a lot of gaps remaining in secondary education, and some of the gaps across the world amplifying when it comes to tertiary education. So since the development goal number 4 in education calls for equity in education across all levels, it is really important that over the next decade we focus our attention to secondary and tertiary education, as well as continuing the progress on primary education. A different look at progress towards education is looking at the gender gaps. And we have seen a lot of progress with females, particularly over the last 3-4 decades, catching up to males. The top panel is showing the situation in 1970. The middle panel is showing gender gaps in education now, and the bottom panel is showing projected gaps in education by gender in 2030. This line here represents 0, so when females and males have equal education, then all the regions would be lined here. So while we see that back in 1970, males had higher education in all regions of the world, we see that that has reversed today, with a few regions having higher educational attainment among females, predominantly high-income regions, and gender gaps persist in regions of the world such as Sub-Saharan Africa, North Africa, and the Middle East, and South Asia. We see the trajectory continuing, with females increasing the advantage over males in the coming decade, but there's still 2 regions of the world where we should focus on education, particularly for girls, and that is North Africa and the Middle East and Sub-Saharan Africa. Now, these gender gaps in education are particularly relevant right now due to the COVID-19 pandemic. Educational attainment for over 1 billion children around the world has been put on hold, and there's a lot of reason to be concerned about when schools reopen, whether girls and boys will return to school at the same rate. So we have an opportunity in the coming year to encourage educational attainment for girls, predominantly focusing in regions of the world where girls historically have had a disadvantage over boys, and ensuring that as the world gets through this pandemic and moves on, that girls are not left behind. Now, all of this is important, not just because education in itself is a viable goal, but also because education is very closely linked to health. We know that it is linked to many health outcomes, and here I just wanted to show one example of the contribution of education to child health, specifically child mortality. And what we have plotted here is the relative risk of a child dying in the first 5 years of life. On the left, as maternal education increases, and on the right, as paternal education increases. So we see that for every additional year of education, we get a decrease in child mortality. So every year of education counts. Education of mothers is more important than education of fathers when it comes to child mortality. And so investing in education of girls and making sure that the next generation of girls, particularly in regions of the world where girls are lagging behind, is going to impact not just economic growth, not just the well-being of those girls, but also the survival of the children that they're going to have in the future. So with that, I will pass it back to you, Terje Andreas, to continue our discussion on the importance of social determinants of health. Thank you very much.
Thank you so much, Emanuela, for your presentation on a very important topic as well. I will now introduce the next speaker, Salma Abdallah, the lead director, project director at the Rockefeller Foundation, Boston University through the Commission. And I now leave the floor to you.
Thank you very much. Yeah, it's been a great learning experience just hearing what the other presenters have discussed so far. So I am going to share my slide just because some of the attendees cannot see the slides, and unfortunately I use a lot of graphs, so it would be difficult not to do so. Just let me know if you can see the slides on my end now here. Can you see my slides?
I hope that the rest of us can see it as well.
Okay, perfect. Yeah, so thank you very much for the invitation to speak today. And I think this is really an important time to talk about, yes, we are investing more and more in the conversations around social determinants of health, but it's also a great time. Unfortunately, it's a sad time for the world, but it's a time that really highlights the power of data in shaping the health of populations, and what can we do to really make sure that the data we have inform decision makings for the future. So before I start talking about the 3D Commission, I thought maybe shortly talk about how the COVID-19 pandemic is really the best example to highlight when we fail to think about social determinants of health and data on social determinants of health in making decisions. And I just use the United States as an example because I think it's one of the clearest example of such failure. But I think the example applies on different parts of the world. So as most of you probably know, the US has the highest absolute number of deaths. Death is due to COVID-19 in the world so far, and honestly, it's a surprising observation if you come from an understanding that investing in healthcare should lead to better outcomes, but that's not necessarily the case. What the case that I would like to make is that the failure in tackling COVID-19, in addition to being a political or a healthcare investment failure, is really also truly a failure of investing early on in social determinants of health. So this is just a slide that shows that in 2015, even though we know, when you look on your left, we can argue about the percentages slightly, but there is a consensus that most of what affects your health really comes from your socioeconomic and physical environment, or the healthy behaviors that you have, which often also are dependent on socioeconomic and physical environment, and then some other determinants. But as you can see, in the United States, expenditure has really focused on medical services rather than investing in the larger determinants of health. And also another example of such thinking about health in general in the US is that you can see in federal spending in the US, the governmental spending since the 1970s has been really focused on healthcare and healthcare programs, despite also not providing healthcare coverage for everyone, versus really investing in social networks or social safety nets. And because of this shortage of investment, we can also see the disproportionate impact COVID-19 had on the American public. So, for example, this is just the latest numbers from last week, where minorities who are also disproportionately low income in the US have experienced higher death rates, as well as higher cases and higher hospitalization in the US, again, because of lack of investment in the social safety nets that would allow them to be able to tackle the pandemic in their communities. We can also see that by income, those who are, and you can look at this graph here on the x-axis, and the x-axis, you'll see that it's the income group, and on the y-axis we have the percentage of vulnerability. So you can see here, the yellow demonstrates that you have a vulnerability to an illness that would make you more vulnerable to COVID-19, and the green light, the green column illustrates whether you have a long-standing mental health condition. And we can see clearly here that those who are in the lowest income groups have vulnerabilities that makes them, and illnesses that makes them more vulnerable to COVID-19, but also that they're more likely to have long-standing mental health conditions. And this is again being exacerbated by the type of decisions that were taken in the US. Just one last slide on the type of impact COVID-19 had in the US is that those who were affected by lockdown measures, so not just COVID-19, but the measures taken to address COVID-19, have mostly been largely disproportionately affected those who are disadvantaged. So if you have a lower education level, you're more likely not be able to work from home, which makes you more vulnerable than later on to COVID-19. If you have a lower income, you are also more likely to not be able to have the option of working from home, which makes you again more vulnerable for COVID-19. And then if you're an ethnic minority, then you're more likely not be able to work from home, which makes you vulnerable to COVID-19. And I'm showing this because this all led to the culmination of what we're seeing right now with a large number of deaths, which clearly just shows that even though there were a lot of models in the US looking into the data of COVID-19, most have not really thought through the data that looks into determinants of health before making such decisions on how can we tackle the COVID-19 pandemic. And it's really a point of time where we should reflect more on how the failure of COVID-19 has been largely also a failure of looking into data on social determinants of health when we're making our decisions. And again, I'm using the US as an example, but many other countries also, if you look at them, if we look at them, we'll see that we can also see some of those issues emerging. So based on this, it seems like COVID-19 has really been a place where highlighted the work that we wanted to do in the 3D Commission. So the 3D Commission is a commission that has combines a large number of experts from the data component of thinking, from the determinant side, from the decision-making side. And the idea was that, and this was developed even prior to COVID-19, with the Rockefeller Foundation, with an understanding that more than 10 years later, following the first publication of the WHO Social Determinants of Health Commission, where are we with social determinants of health? But also asking, 10 years later, we're also in a very different world when it comes to data, what it means to have data, what type of data do we have that would inform our thinking about the different determinants of health. And lastly, we also wanted to make this something that is practical, that people can use to inform their thinking in the future. So we wanted to combine the three areas, so hence the 3Ds. We wanted to combine thinking about determinants in addition to thinking about data and what data means right now, and ultimately how do we combine the two to make sure that we have decision making that really helps improve the health of the global population. So as I mentioned, a lot has been written about social determinants of health. What we're aiming to do right now is looking back and saying, okay, this has been written over the past few years. What can we learn as a global population about the determinants that shape the health of all of us? The second component is data, and as I mentioned, data and what we think about as data has changed a lot. So what we're trying to do in the 3D Commission is really look into, yes, we do have traditional sources of data that we can use to help think about determinants of health, but are there also other sources that we can tap into that could help us improve the thinking on determinants of health? So for example, just one quick example is the social media data. So can we use social media, for example, to try to look into different determinants of health? And can we use data that is timely, because social media is more timely than the traditional use of, for example, data sets or surveys? Can we use this data to try to help inform our decisions on determinants of health? And finally, the last component is decision making, the action of making decisions, especially important ones. And here we mean actions not only by those who are in the policy making realm, but also actions by those who really make things work in different countries. So not actions on the high level, but also actions those who are in the Ministry of Health, those who are working in the bureaucracy of the Ministry of Finances in any country, and how can we really help them to make decisions that would improve the health of the population. This is the essence of the 3D Commission, is that we want to look into insights that would help us think about social determinants of health. How can we really look into data and data science to try to inform the decision making around those social determinants of health? And I want to say, even though this is largely an intellectual exercise where we have commissioners who have a lot of experiences, such as Dr. Samira Asma, it's also trying to be more practical. So in addition to having a report, we're also working with policymakers throughout policy discussions to see what type of realistic recommendations that we can provide for them. And the hope is that we can publish a final report with realistic recommendations for policymakers by UNGA 2021. But we also wanted to look into creating in the future, hopefully, and this might be an open space here then also for collaboration, can we create a global data set or a global database that looks into the different determinants of health and can help policymakers around the world trying to make decisions about the health of their own population. This is an ongoing project that we're working on, and hopefully we can collaborate with other entities to try to make that happen. A few challenges that we're encountering as we're going through our thinking in the 3D Commission is the first one is we're realizing context matters. And when we talk about social determinants of health, we really need to be careful what are the contexts that we're discussing. Education the effect of education would definitely differ, even though it's salient across the globe. How would that practically affect decision making will probably differ from one country to another. So that's one thing we're looking into. Also, that big data is, even though it's been a topic in the mainstream academia for a while, it's not really well defined, and we have space here to try to think about what are the advantages we have from non-traditional data sets, but also what are the pitfalls that we need to think about. And here comes accountability and data privacy issues that we need to really consider. And finally, that there are, as the speakers before me highlighted, there are data inequities on large scale across the globe, and what can we really do to try to address those type of data inequities. And finally, that what we really aim to do, given all of those challenges, is really, by the 3D Commission, create a lens where decision makers across the globe take those three components in mind when making their decisions, rather than being able to inform them with concrete actions. Just again, as I mentioned earlier, because of the differential context, it would be very difficult to have a final recommendation that is one size fits all. So we're trying to also be aware that maybe our largest contribution to the conversation would be developing a lens to looking into different decisions, rather than telling decision makers exactly what to do across the globe. If you're interested in our work, please go to our website and you'll find more about the 3D Commission and what we're hoping to do. Thank you.
Thank you, Salma Abdullah, for your very interesting presentation. I will now introduce the next speaker, Nicole Valentine. And your presentation should be uploaded in a second, I believe. So please go ahead. Thank you.
Okay, thanks very much. I know we're running a bit out of time, so I'll try to be brief. I'm going to share with you some lessons on data to policy for social determinants of health, but from the perspective that addressing the social determinants of health needs multi-sectoral action, and also from the perspective of the SDGs, which does offer us that opportunity. Let me try and move my own slides, otherwise, hang on. Right, let's go. Okay, so I think one of the challenges we found working on the social determinants of health is depicted in this graphic, which was collected by Michael Marmot's group, a few of these graphics depicting the relative share of determinants. In 2017, they published a paper on this, but this graphic, when speaking to policymakers, was very, very important communication tool. It's very simple, but in fact, the arithmetic behind it, I think, is very complex. And that's why I'm so excited with what Emanuela's group is going to be doing on the burden of disease. I think this is very important. So in addressing the social determinants, we were operating from this framework, which separated determinants into structural determinants and intermediary determinants. We then went on to promote really why this was important for addressing social determinants, was important for health equity. And as you can see from the previous slide, the social determinants have a direct impact on health through the conditions of daily living and working. There also is then the fact that what we are advocating for, and is shown by several studies, but I don't know if it's shown globally yet, is that social determinants explain the greatest proportion of health inequities. Thirdly, of course, in social determinants, we've looked at a lot of studies that show how social determinants structure behaviors, which are so important, healthy behaviors. for many things to do with COVID. Now we're seeing it also NCDs, etc. So the health behaviors are extremely important. Health inequities, other speakers have said, accumulate over the life course. I just wanted to make also the point that of the syndemics, has been a lot published lately about the syndemics in COVID, the interaction between COVID susceptibility and NCDs. So it is with that sort of landscape, it is quite a complex area, I think, to grapple. And we've certainly struggled with it at WHO, I would say, and particularly not having the right data ready at the right time for policymakers. A few years ago, working with money from Rockefeller Foundation, we started to think about what kind of mapping of data did we need. And sort of bear with me a bit because this is perhaps less academic. We looked at the idea that taking the framework you saw previously and said, okay, so we need some indicators of how is governance functioning, how are social policies functioning, and how are environmental policies and programs functioning to address health inequities through the social determinants. We then need information regarding the equity in what we distinguished between the structural and the intermediate social determinants. We called it equity in conditions. So what are the health promoting conditions that people are living and working in? And how are those conditions also promoting access to health services? This project was particularly looking at the interconnection between universal health coverage and determinants. Finally, the WHO has done some work building on the initial work that Emanuela was involved in setting up on the inequalities in health outcomes. So that work from 2000 built up further. So by 2015, my colleagues Ahmad Hossenpour, he had developed quite a good database with inequality measures, initially with population health outcomes, but increasingly of service coverage rates. And then coming with that has also been, of course, out-of-pocket expenditure under universal health coverage. So we then said, okay, let's focus more on the equity in the conditions and equity in actions. And in trying to look at conditions, I think one thing that's inhibiting us as scientists is a different set of definitions for what are the social determinants of health. Maybe it's impossible to come to a common set because of context, as one of the previous speakers were mentioning. But I think it's quite important to have more definitions in this field. We started in 2014 to try and develop a common set that could be understandable by policymakers working in a number of 4 or 5 countries. And at that stage, we also mapped them to the upcoming Sustainable Development Agenda in 2015. We had several workshops with policymakers, and we looked at the presentation of indicators with dashboards, with geographic, with maps overlaying different social determinants, what was going to be more intuitive, useful for policymakers. The maps and the GIS seemed to be very, very important. We also looked at ways of stratifying determinants, looking at intersections, which at that stage it was just becoming popular in the literature, and then went on to the multi-level analyses, which I think then our European colleagues took between 2015 and 2019 to really drill down into policy relevant, the multi-level type analyses in order to communicate with policymakers on which areas of social determinants they needed to take action. And they came up with 5 very simple labels, which I'll show you shortly. So I'll sort of breeze through the next slide. We then also tried to work on defining what would be the definitions for these different types of indicators. And here you see the results of some of this work in 2016 that was published in the WHO Bulletin. So we said that we've got SDH-focused indicators, and then we divided those again into those 2 categories with definitions, and the 2 categories being more the action areas versus the actual conditions of daily life. Then with respect to the action areas, we've also looked at the Commission's recommendations. You can't read what's on the screen, but just to tell you the principle, on the left, we took the Commission's recommendations, and here I'm talking about the WHO Global Commission on the Social Determinants of Health that submitted its report in 2008, so this is quite some time ago. But we mapped those to what could be potential indicators in the SDGs. And you'll see on the third column, we looked at what was the evidence for it. And you'll actually see this list is quite small if you look at governance, intervention, socioeconomic, and environment. And the list represents what was measurable around about 2015, 2016 in terms of what data there was. You can see it's a very small list, and a lot of the indicators that are being collected through the SDGs are not directly relevant to the measurement concept as envisaged in the Commission's recommendation. So I think there's still quite a way to go. Finally, my colleagues in the European office worked on decomposition analysis, which was also something that we had done in the early 2000s with different countries, but they really brought this up to a huge scale to cover 36 or more countries in the European region, with very easy to understand labels for policymakers, talking about inequity in access to and quality of healthcare, attributing 10% of the gap between the most deprived and the least deprived households. It's 35% for financial insecurity, 29% for poor quality housing, 19% of lack of trust, sense of belonging, issues to do with education as well, and inclusion that it brings about, and 7% for the actual interface of the working conditions, more occupational health. So I'm going to end off really with, I think, the last slide, which is another representation, which is very important, which is the feasibility that something can be done in a short space of time. For policymakers, inequity has seemed like this never-ending problem that can never be solved. And I think this kind of graphic and these kinds of information is very important. Here you show on the bottom axis the reduction in the percentage points of the gap between the most advantaged and the least advantaged wealth quintiles. And then on the left-hand side, you show that if you have, let me take the third one down, maybe the fourth one, for increase in social protection expenditure by 1% of GDP, you're going to be able to reduce the gap by 0.5% within 2 to 4 years. If you contrast that with housing and amenities, you're going up to almost a 2% reduction in the gap within 2 to 4 years, which is within a political cycle, which is very important for policy action. That's all for me from now. So I hope you found that interesting, and I look forward to the discussion. Thanks.
I would now like to thank all the speakers for their presentations. As we now have around 4 or 5 minutes, there will not be time for much discussion, but I would do like to ask our speakers if they have any final remarks to any of the presentations we have heard. Just raise your hands if you have anything to add. Otherwise,
I have a remark.
Yes.
Well, I think just a general remark, which perhaps Terje and I were discussing earlier, which is I think that it's also about action, bottom-up action and top-down action. So it's not having the data. I think the reason why it needs to be communicable in a way to the general public is because the policymakers respond to the general public. That's the one point I'd like to make. The second point is that I think the foundation of vital registration, vital statistics cannot be overemphasized. It was one of the first recommendations in the data section of the Global Commission on Social Determinants of Health. And what's very worrying, I think, is the consistent undercutting of public institutions globally. And vital statistics does rest on having good public systems. You can have cooperation with the not-for-profit private sector, but really it is a fundamental public duty, one would say. So I think this is a challenge going forward.
Thank you, Nicole. Any others?
Yeah, I don't think I can show my video because it only allows for 4 videos at a time. But I think the challenge for us, and thinking more about the work that we're doing, realizing more and more, it's also a challenge for us, those who are working in public health, as well as the healthcare sector, to try to really engage with other sectors that might have data that would be helpful to us, but we're just not, we're not really conditioned in our thinking of using data that we're not comfortable with. I think that is where we can really benefit from other sources of data that are available out there that could really inform our decisions with determinants of health.
Thank you so much. Any other final remarks? Last minute, it has to be very short. Otherwise, I suggest that I close this with a short summary. The main take-home message is that we need evidence-driven surveillance of socioeconomic inequalities and health equity globally. We are not there. We will get there. We are getting closer. We need better data, and this includes going deep by using data that goes deep, like genetic data. We need data on societal level, but all these data cannot be obtained everywhere. So today we have discussed how we can take new steps in ensuring global comparability by harmonizing the data we have, by integrating education in the GBD, and to make, for example, spatial data, which also lies in the future, and to a large extent in the present. We need to improve our research infrastructures with a comparative scope, and ensure that the data becomes available as well for research policymakers and practitioners. We bring research, international organizations, and policy institutions together in dialogues like this one, the one we have now. And finally, in the last 30 seconds, we just made this, so thank you all. A big thank you to all of our eminent speakers, and thank you to all of you who were able to join us today. Thank you so much.
Thank you. Bye.